I'm gonna go through it, I think. We have to just do the, yeah. We can, Oh, you good? Okay. All right, ladies and gentlemen, have your seats. We can get going. Okay, man. All right. Can everybody have a seat? Thank you. All right, welcome everyone. We're going to start with a attendance via roll call. As soon as Charlie says we're good to go. We are good to go. All right, when you hear your name, please tell us that you are here.
When I call your name, please say present. Robert Winchell.
Present.
Joseph Schenker.
Present.
Michael Vatch. Robert Ackerman. Laura Ipoli. Stuart Kessler.
Yeah.
Matthew Fain. Wallace Carter. Eric Cohen. Kevin Winjal. Cindy Basilios. President. Grace Cacciolo. President. Mario Gonzalez.
Present.
Glenn Aceta.
Here.
Bradley Kaufman.
Present.
Nathan Rice.
Here.
Pamela White. Here. Adrian Patarello. Nicholas Alexander.
Here.
Doug Isaacs. Devin Howard.
Adrian Ferrero was, I think you something for this over there.
Yeah, the alternate just.
We can talk
That's a
about-
fellow that graduated.
That Doug
Right.
is here.
Kevin Ward. Andrew Marie Durdenti. Andrew Dahl. Jeffrey Raybridge.
Here.
Lauren Costerco. Reed Caldwell. Jonathan Berkowitz. Louis Marshall.
Present.
Michael Redliner. Dominic Bettinelli. Ethan Rendon.
Present.
Peter Wire. Eric Plittinger. Paul Barber.
Present.
David Benelli. Mary Foote. Mark Cantor.
Here.
Ed Jarvis.
Present.
Nicholas Perry. Joseph Bowe. Sean Graves. Jessica Van Voorhees. Benjamin Zabar.
Here.
Matthew Harris.
He stepped out, he'll be back.
Robert Krupe.
Present.
Arthur Cooper.
Here.
Eugenia Langsam. Anthony Shalish.
Present.
We have a quorum.
There is a new fellow that is going to be sitting here for Doug. Who's going to alternate for Doug? What's your name?
William Hauser.
Okay, so Michelle. William Hauser is going to be Doug's alternate, one of the EMS fellows.
HAUSSNU.
NER.
NU.
Thank you very much. Okay. All right, well, thank you all for attending. We really appreciate it. It's going to make my first point a little bit less aggressive. But first, I'd like to entertain an approval of the minutes from the April 18th meeting. That was the last time we met. Does anybody have any questions about the minutes? Changes, concerns, comments? Hearing none, motion to approve? Second? Okay, all in favor of approving those minutes? Just raise your hand. You're not to vote on the roll call. Thank you. Anybody opposed to the minutes? Hearing none, okay, minutes are approved. The correspondence report. I'd like to just kind of quickly go through them. It's a long correspondence. There's some enforcement actions that do have to be read in it. Before we get to the enforcement actions, at the previous medical standards meeting, Dr. Aceta mentioned Captain Gil Medina and Dr. Paul Hansard, both from the New York City Fire Department. Dr. Hansard has been a telemetry physician for about 20 years now, 40, even more than that. I keep forgetting where we are at the time. And Gil was on the critical stress debriefing team and critical support. I just would like to, in recognition, just a moment of silence, if you would, please. Thank you. Okay. Some enforcement items that have to be read into the minutes. DOH enforcement's Kyle Faheen from Syracuse, New York, EMT number 437740. A formal reprimand is placed on probation for 3 years effective 5/3/23, and assessed a civil penalty of $2,000 and $1,500 is pending. No further violations during probation is stated pending. Vincent Vixiella from Selden, New York, EMT number 310254, revoked effective 5/4/23. Robert Ortiz Jr. from Brooklyn, New York, EMT number 378919, surrendered effective 6/1/23. College Point Community Ambulance Corps in College Point, New York, agency 7343, surrendered their operating certificate effective 6/7/23. Danielle Winters from Hopewell Junction, New York, EMT number 472680, suspended for 1 year effective 4/25/23. Francisco Garcia from Shirley, New York, EMT number 430670, revoked effective 6/11/20. Sean Woods from Star Lake, New York, EMT number 405691, was suspended for 1 year effective 6/1/23. That suspension is stayed, and that person will be on probation for 3 years effective that date, 6/1/23. And Javante Osterhout from Albany, New York, EMT number 375786, was surrendered effective 8/7/23. I'm sorry, one more. Brian Torres from Spencerport, New York, EMT number 266687, was suspended for 1 year effective 7/17/23, and that was stayed and on probation starting on that date. Okay, there's a couple of events that were distributed by email. There's a CCEMTP course hosted by Center for Emergency Medicine of Western Pennsylvania from November 6th to the 21st and March to the 6 to 21 of 2023. Which if you need to have any information about that, please let us know. Critical Care Cardiology Symposium at NYU. That will be on October 20th, which is Friday, and October 21st. The NAEMSP Foundations of Medical Oversight course will be November 15th to 16th. The cost is $200 for physicians and $100 for resident physicians. That could be registered on the portal. Those are the immediate classes that are coming up. Finally, there were 2 REMAC advisories that were sent out since our last meeting. REMAC advisory 2023-04, which is the emergency change pain management paramedic level protocol, and 2023-05, which was the updated change because that had to be revised. Any questions about those correspondences? All right, the executive committee met immediately prior to this meeting. There were a few items that were discussed. I'd like to bring them up for discussion, and then we'll move into the subcommittee reports. First, a nominating committee was formed to review nominations for the current for the new year. This year, we'd have to re-vote on all of our officers. The current slate is the standing officers right now who have all agreed to be on the slate to be reappointed into their position, or re-voted into their position. That would include myself, Dr. Brad Kaufman as the first vice chair, Dr. Jeff sorry, as the second vice chair.
We're all tired.
I'm very tired right now, but I'm going to get through this quickly. Dr. Benelli as the chair of the Medical Standards Committee, Dr. Paul Barbara as the vice chair of the Medical Standards Committee, Dr. Lai as the chair of the protocol committee, Dr. Barbara as the chair of the CNC committee, and Dr. Michael Redlener as the chair of the quality assurance committee and improvement. We are looking for vice chairs for both the protocol committee as well as the CNC committee, as well as the QA committee, if anybody's interested, to help grow our leadership. That would be much appreciated. And if anybody would like to submit a resume or a nomination for any of the other seats, that can be done at any time. Please send them to Marie, and they will be announced at the next meeting. Any questions on that slate? Okay, hearing none, we'll move forward. Along with that, we are going to look very carefully. We have said this many times in the past, and I know you all see Michelle's emails about forums and ability to hold meetings. We have said this in the past that you must attend at least 4 meetings a year, and that we are going to be looking at the membership to see who does not attend, and those people will be removed and replaced with new people who want to serve. It's really important that we represent ourselves in this region as strongly as possible. We all know that the state is making a push to basically remove REMACs and remove REMSCOs and operate everything at a state level. And I think all of us in this room would agree that for our purposes in New York City, that doesn't work. We have too many operational and quality, and the size of our system does not allow for everything to be done at a state level. We have a very active, very large EMS physician community here, and we need to actively participate. That means coming to meetings. I know that the live meeting rule or the open meeting law requires us to have this in person. So you have to come to a meeting. That's the rules. And we are going to look at the list. People that have not been coming will be removed. For organizations that submit their membership, they will be told that those people cannot be renewed without specific rationale behind it. So if you're not showing up and the organization that submits your name wants to just sign off, we're going to keep the same person, we're not going to allow that, because there are people that want to be involved and that should be involved, and I think we need to move that forward. Any questions on that? Again, I'm preaching to the choir because you're all here, and I really thank you for that. But tell your friends that if they're not coming, we're going to have to remove people. The next order of business is, the next thing that we discussed is the online medical control facilities in the region. New York Methodist Hospital, which has been providing medical control for about 20 years, will be stopping operations as an online medical control facility as of January 2024. That's going to leave a lot of volunteers and voluntary agency and proprietary agencies without medical direction for their online medical control facilities. We had a brief discussion at the executive committee about what options there are for this, but I open it up to all of you. You know, some of the options are to have a regional online medical control facility, which would be essentially an online process so that we as physicians could all take time and maybe once a month or whatever it is and participate in the online medical controls for agencies. Another option is to go to an outside agency like H&H and ask them if they'd be interested in providing online medical control. This is a resource we need for our region. And unfortunately, we are limited with the amount of facilities we have. We can't ask the fire department to do it. Their volume is just too high and it would not be appropriate. So any ideas? I'd love to hear them. Again, like I said, an internal regional online medical control facility, or going to health and hospitals and seeing if they'd be interested in doing it are the two ideas that we're going to pursue right now. But I'd love to hear more ideas. Kevin.
Is there a new need that you work for additional contract, or is it need that
I think it's a little bit of both, but I think it's existing need because Methodist has been the online medical control facility for most of the volunteer agencies in the region, a few of the proprietary companies, and a few of the volunteer agencies. So That's a large resource that handles about 5,000 to 6,000 calls a year, which is not going to be available. So those calls have to be managed somewhere. Now, some of the larger volume is being absorbed in some other agencies, but there will still be a need for volunteers and for other agencies to have medical control. We'll go to Nick and then.
So do the individual agencies have any consideration of creating their own online medical control REMAC, certified online medical control centers where their own doctors can do that perhaps?
Well, I don't think any of them are significantly large enough to support an infrastructure like that. As a region, though, we kind of have to figure out how we can help our volunteers and our other.
Or can some of these agencies bring it together and have?
Well, that's the plan, and who's going to be the agency who's going to be the housing, the entity is the question, but that's essentially what we're trying to think about. Nathan.
Yeah, I'm just curious that volume you talked about, how much of it is commercial and how much is it volunteer?
Well, Hatsola is the largest volume that we see at Methodist. It's about 80% of our volume of the 5,000 to 6,000 calls a year. So I think that they have a plan in place already. So I don't know that would be included, but we're talking about the rest of the volume, which is not insignificant, but it's not overbearing. I don't think you're talking about, 10, 15, 20 calls a night. You're talking about 1 or 2.
How many alarm control facilities are there actually? Because I
I think
know
there
now
are
that it's
5.
closing, and then also North Shore, Staten Island, right? They closed earlier as well.
Right, so there's Northwell has a centralized, there's the fire department. Mount Sinai has one, but it's really only for their process. I think Maimonides,
Yes.
I think that might be it. So, yeah, I think Jamaica was interested in doing it, but they haven't gone through the full process yet. And they're only interested in doing it for their own agents.
But we appreciate you looking at other options because we're doing 85,000 calls
Correct.
a year. At least, and during COVID, we're at 100
Correct. So just again, the understanding was that this could not be absorbed by the fire department. It's just how do we manage it from the region?
They been discussions with veterans about how they're gonna have them do this. They're just gonna say, hands up, I'm done on January 1st.
No, there's going to be a discussion with all the different agencies. We're going to make sure that everybody is appropriately.
What I'm saying is that there's a common level of what to drop out, they don't have to dropping out. They add into the community, so to serve the community. They can't just have stop them. They want to stop, I'm gonna control why. You must go to BLS. Until you get there, if they're.
We're talking about the ambulances.
I'm talking if the medical control is running an ALS unit and they decide to drop their medical control, those buses have to go to BLS until they negotiate with with us to say how we're going to handle it.
Right, so-
Drop it and say, well, you guys take it.
Well,
That can't happen. What's not going to happen?
okay, well, so number one is New York Presbyterian Methodist Hospital can stop their medical control whenever they want.
Right, but then.
That's
then-
stuff.
Right?
No,
Correct?
we're not talking about the ambulances. They provide online medical control for Hatsola, Columbia area,
And their bus.
Park Slope.
and then
They
even
do
bus-
not. They do not provide for their own ambulances. Their own ambulances go through the fire department and their transfer center ambulances go through Cornell. So this is external. It's not their internal NYP ambulances. But all those external ambulances need to have medical control. We're aware of that. We're not trying to shut the switch off and leave anybody out in the cold, but this is a process that we have to resolve.
Yeah, it's interesting. Dr. Childs brings up a point that to become an online medical control facility, it's a process. You don't just say, effective tomorrow. Call.
Correct. And
Now,
now
the shutting down should have some kind of process too. Now, I don't know how long Methodist was planning this, but if this is the first notification, it's already October.
this is
You're
not
talking,
notification.
okay, but this is the first we're hearing about.
Right, but the ambulances that are using us have been, especially Hatsola was told this like
Right.
6 months ago.
Right.
Other ambulances are aware. Again, and this discussion, by the way, started at a regional level. We started looking into technology to do it regionally at the beginning of the summer. We just haven't met.
Right.
That's the only reason that we're only finding out about it here because the first meeting.
I understand that, but the ambulance service, they have to find something, right?
Right.
But the process is a regional process. And
Correct.
it doesn't seem fair that it takes a process to become one, but to shut down, effective January 2024, we're shut down.
That's the goal.
Staten Island North did the same thing to us, right? When they left. I mean, it was just essentially January 1st of 2023, we're done.
Right.
It doesn't seem like a fair process.
But no one is being, we're not stopping cold turkey and saying we're gonna leave people on the cold. All the ambulances have been notified, they're all looking for options. We're continuing to do it until everybody has an option. But that is our target goal, Jen. Does that make sense?
We don't have contracts with these online medical control facilities.
Nobody's
They
required
can
to keep
stop.
it.
Yeah, they can stop.
Right, but there's a procedure that has to go through to be, we should have a procedure that says you have to give us at least this much time. Right, it's only fair.
Then we need to write that into our.
I think we need to, when we revamp this thing, I think we need to put this in
6 months notice or whatever.
something, right? Because I'm first hearing about it now, right? And maybe
But
we're
again,
discussing it,
none of
we
this-
haven't met, it's not an excuse, right? It's never an excuse.
But none of this is gonna fall in the fire department at all.
But that's not true.
Yeah.
You know it's not true because they're gonna call anyway.
They're not gonna call you. None of these ambulances are calling now.
We get volunteer calls now. We get volunteer calls.
None of these ambulances,
But that's not true. No, that's not true.
you know,
They call, because each one's gonna say, I only have a couple of calls. Let me just call them. Northville does this when they don't want to deal with anything at time.
let me be clear. We
But
are
this is
not
the
turning
problem,
off
we don't
the system. We're not turning off the service until the ambulances that are using us have an alternative system.
Fire department can
So
only-
we are not-
only expand to a limited degree.
No one is
We're at the
expecting
break.
fire department to do anything for these ambulances at all.
It's not gonna happen. I'm telling you.
I'm sorry.
But it's not gonna happen. I know it.
How is it not gonna happen? We're not stopping until they have another option. And that option is not the fire department, which is what I made very clear. Hey, Tom.
Okay, well, think-
Freeman acting in that they have the capacity to take.
Yeah, that's what I want to say as well. Matt said that Maimonides is able to take on other agencies. But that might help blunt at least part of the.
I think that that's part of the process.
But I agree with what with the concerns that are raised, obviously.
No problem.
Quick question, the volunteer agencies, do they generally pay for the service of?
Volunteer agencies have, Methodist has not charged volunteer agencies. We charge proprietary agencies, not volunteers. That might not be the case going forward, but that's what historically we've done.
Methodist was very good to the volunteer sector, providing them with free online medical control to any volunteer that wanted it.
Which is a complicated issue, but as an EMS physician, a lot of people are EMS physicians, like, you know. I think that uncompensated, undercompensated time, medical control is an issue, you know, that. Whether it's someone's probably gonna have to pay for that physician time to.
Right.
That's part of what we have to look at.
Anyway, I think we do need to consider a regional approach to this for all of these different agencies, and we can charge them whatever we think is appropriate. So again, that's not a question. And as far as Methodist going offline, that will not happen until every agency has an alternative. So I don't think that there's a concern for the fire department that they're going to get any additional calls, because we're not turning it off until the doctors are still there, the phone lines are still there. Nothing is going off until everybody has an alternative. Okay. Any other options that we could think of? All right, so that was the subcommittee, that was the executive committee report. We will begin with subcommittee reports. Dr. Benelli, medical standards.
Okay, so medical standards met just before this meeting. There are a couple of items that are being brought a second motion from medical standards to REMAC for approval. CNC, Dr. Barber is next door, he's not here presently, but there's a change to the manual where they want to make the time to submit CME limited to 45 days. Board by Kevin Ward. I don't think we need to vote on this. It's just something that we need to be aware of. And the protocol committee has a couple of motions that are being brought up as second, and I'll let Dr. Lai present them. Sorry, I think we need to turn on the projector.
All right, so we're waiting for the projector to warm up. The first protocol that's coming forward from medical standards is to the general pain management protocol. You can see that the projector is starting to warm up, but where this is again like a more of a clarification again in terms of like what the the intent of the protocol was, in terms of, for having paramedics to be able to fight for any opioid medication, for any dose that they are going to be, administering, including the initial dose, is that they would be able to incrementally titrate those doses to effect. So you'll see that there is the proposed language change both for the morphine and for the fentanyl, that there's a statement that's in the beginning that morphine or fentanyl are able to be administered in incremental doses titrated to effect. And that's going to be including the initial dose as well as any subsequent repeat doses.
So essentially, this is just shuffling of words, moving the second part of option C and D from the middle of that option to the beginning of the option, in line of into what we have always wanted this protocol to be. Any discussion?
For clarification, if they were to give 3 milligrams, they would give you 2 milligrams, that's the first dose, and then they would give you another couple of alphas.
Yes. Yes. You know, there's room for clinical judgment. You know, which I think is appropriate, and I think that our providers are capable of doing, and we should give them that leeway.
I think the protocol was implemented.
Anything else? All right, so this will be a roll call vote on this change.
Okay, please state whether you are in favor, opposition, or abstaining. Glennis Seda,
In favor.
Kristen Kaufman,
In favor.
Dario Gonzalez,
In favor.
Nathan Reisman,
In favor.
Pam Lai,
In favor.
Nicholas Alexandru.
In favor.
Is Devin Howell here, or who is Dr. Isaac's alternate?
William Hasner in favor.
And your first name is William?
Yes.
Jeffrey Raybridge,
Favor.
Reed Caldwell, or Jonathan Berkowitz?
I think it's Paul Barber.
No, it's a
Wait a minute, you said, oh, it's different, sorry, no, I take that back.
Lewis Marshall,
In favor.
Michael Redliner is absent. Save Dr. Schenker for last. Joseph Bo, not here. Dr. Cooper,
He's here.
in favor, abstain, or oppose? Thank you. Robert Winchell,
In favor.
Ed Jarvis,
In favor.
Mark Cantor,
In favor.
Robert Krupe,
In favor.
Mary Foot. Laura Ivacoli, or Stuart Kessler.
In favor.
Thank you. Matthew Fink or Wallace Carter. Kevin Munjal, Cindy Basilios,
In favor.
Matthew Harris,
In favor.
Jessica Van Voorhees, Benjamin Zabar,
In favor.
Paul Barbara, Jonathan Berkowitz. Okay, I'm gonna put him down as abstaining because he's not here.
Yeah.
David Benelli,
Yes.
Eric Blutinger. And Dr. Blutinger, you are Peter Wyer's replacement, no, or alternate? Dr. Wire still here? Okay, we'll check, because I have a feeling that he may be retiring. Okay, so it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21. It passes.
Great, thank you. Dr. Lai.
So the next protocol that we have The next in motion change that's coming from the Board of Health Committee on Medical Standards is a change to Appendix B. This is the universal approach to the EMS call. And in particular, we're looking at the primary patient assessment section where as part of the circulation steps. This is just a change to remove the elevate leg as needed, and this is going to be consistent with current curriculum teachings. So this is the motion that's coming forward.
Is there any questions for Dr. Lai? Hearing none, please go on to a vote.
Okay, once again, in favor, opposed, or abstained. Glennis Sata.
Yes.
Bradley Calvin.
Yes.
Dario Gonzalez,
Yes.
Nathan Reisman,
Yes.
Pam Lai,
Yes.
Nicholas Alexandru,
Yes.
William Hauser,
Yes.
Jeffrey Raybridge,
Yes.
Jonathan Berkowitz. Reed Colvin.
Okay.
Lewis Marshall,
Yes.
Arthur Cooper.
Yes.
Robert Winchell,
Yes.
Ed Jarvis,
Yes.
Mark Cantor,
Yes.
Robert Krupe,
Yes.
Stuart Kessler,
Yes.
Kevin Winjal,
Yes.
Cindy Basilios. Yes. Matthew Harris.
Yes.
Benjamin Zabar,
Yes.
Paul Barbara. David Benelli
In favor.
and Eric Blutinger.
Yes.
Thank you. Next, Dr. Lai.
All right, so the next change is a change that is in the GOP section. This is in particular in regards to the alternate treat in place and or alternate transport destination decisions. So part of these that I'll be kind of going through in a little bit more detail, as well as the accompanying appendix that was already approved at the standards that was in the last spring. So the first change in the GOP section kind of puts, again, like this is so just to preface this, so again, like this is these changes are put forth by the consortium of the agencies who are participating in alternate transport destinations and treatment place options, even though the funding for the official ET3 project will be ending at the end of the calendar year. But these agencies have decided that they are still going to be moving forward with this and requested these changes to our GOP as well as our appendix section to match with what they are seeing, what they are seeing is going to be needed in order to move forward with implementation. So the first change that we have is that to the GOP section, we would like to kind of like offer this as being like a sort of like the standard in terms of like the treatment and or transport options of the offer to the patient. And that as sort of like the first choice or first choice that the offer that the patient could either be, again, if they qualify, that they be offered either treatment place with patient release, or they are offered the transport to an alternate destination if they meet the criteria that in the appendix that we will speak about in just a second. And then only if that patient refuses those options that they will be offered transport to the appropriate 911 emergency department. That's sort of like the first change on here. Subsequent changes in terms of like language is going to be will make more sense in terms of the what will be proposed in the in the appendix, where we will then remove like some of the language and the criteria that's in the GOP section that kind of made some specifications on there that are no longer being proposed in the appendix.
Any discussion on this, guys? Any questions?
Or it might be like my.
Yeah, just to keep everyone awake, we have the flashing version.
Yes, medicals, REMAC might cause C. Any questions about those changes? Basically, this is to use the alternative destination more effectively. for the treat and place option. All right. Well, hearing no discussion, I guess we will entertain a vote.
Okay. Glenn Esteta,
Yes.
Bradley Kaufman,
Yes.
Dario Gonzalez.
Yes.
Nathan Reitzman,
Yes.
Pam Live,
Yes.
Nicholas Alexander,
Yes.
William Hausner.
Yes.
Am I pronouncing your name correctly?
Yes.
That's amazing, actually.
That's a double.
That's two votes.
Jeffrey Raybridge.
Yes.
Louis Marshall,
Yes.
Arthur Cooper,
Yes.
Robert Winchell,
Yes.
Ed Jarvis,
Yes.
Mark Cantor,
Yes.
Robert Krupe,
Yes.
Stuart Kessler,
Yes.
Kevin Monjal,
Yes.
Cindy Facilios,
Yes.
Matthew Harris,
Yes.
Benjamin Zagar,
Yes.
Paul back yet? No. David Benelli
In favor.
and Eric Lutiger.
Yes.
Okay, carries.
Great. Okay. Pam, whenever you're ready.
It's just a second, I just got a little bit of break. Really on here, but hopefully this will move a little bit forward. So the next one is the accompanying appendix P for the inclusion and exclusion criteria that was referenced in the GOP section that we just talked about. Where now that instead of having a rather extensive list for both the inclusion and the exclusion criteria, we now have a lot of the criteria are now, for those that are familiar with the 911 system, currently reflects a lot of the language that's in the current RMA policy that the 911 system uses. That is like a patient must fulfill the following criteria, that they have to have a decisional capacity, as well as having, excuse me, for inclusion criteria, they have to have decisional capacity. They have to have a low index of suspicion for a medical treatment or that low index of suspicion that requires any sort of medical treatment or transport to an emergency department would be required. As well as they would also have to be in a safe environment. Other issues in terms of like that the patient must not receive any sort of administration of any medications or treatments. Except for things such as bandages, gauze, ice packs, and oxygen. The other two changes that are slightly different from the current RMA policy is that patients may still be included if they receive treatment for hypoglycemia and who post-treatment have normal vital signs and normal mental status. In addition, patients who receive nebulized medications for the treatment of reactive airway disease. And also who are post-treatment have normal vital signs as well as a normal respiratory status, they may also be as part of the inclusion for these patients for treatment place as well as for the alternate destinations. There is also the slight change for the behavioral health inclusion criteria. In that, so these are going to be things that are going to be only for on-scene mental health providers when they are available, and it's not specifically not through telehealth, that there's also just the removal of specific presentations, including depression or anxiety symptoms. Sort of kind of going hand in hand, the exclusion criteria, again, mirrors what the current 911 RMA policy is that they have to have, patients, these will be including patients who have a high index of suspicion for any sort of medical traumatic condition that could result in a life-threatening or life-altering outcome. And then also to similarly for behavioral health exclusion criteria. This again, it's like this, for the exclusion criteria, we cannot have patients who are actively withdrawing from substances, including alcohol, opiates, or other drugs. That was also included. But this was something, this change in the appendix was something that we have discussed in the medical standards and past medical standards in spring.
Any questions for Dr. Lai? I think that this process is just a little bit streamlined with these changes. Makes it a little bit easier. Hearing no questions, we will vote.
Okay, once again, in favor, oppose, or abstain. Glennis Seda.
Yes.
Bradley Kaufman.
Yes.
Dario Gonzalez.
Yes.
Nathan Reisman.
You step down.
Pam Lai.
Yes.
Nick Alexander.
Yeah.
Doug Isaacs. William Housen.
Yes.
Jeffrey Rayburn.
Yes.
Louis Marshall.
Yeah.
Arthur Cooper.
Yes.
Robert Winchell.
Yes.
Ed Jarvis.
Yes.
Mark Cantor.
Yes.
Robert Krupe.
Yes.
Stuart Kessler.
Yes.
Kevin Munjal.
Yes.
Cindy Basilios.
Yes.
Matthew Harris.
Yes.
Benjamin Zabar.
Yes.
Paul Barber. David Benelli.
Yes.
Eric Lutinger.
Yes.
Carries.
Okay. Dr. Lai.
All
Anything
right,
else?
so the next protocol that we have for discussion will be changes to the pediatric severe bradycardia protocol. Just try one more time.
Oh, what's going on? with our whole-
So I'm just gonna go offhand, so for the severe bradycardia pediatric protocol, for the first change that we had, that was clarification to the CFR section, where we do have that, again, this was a correction that there was a little bit of a stopgap in terms of like if patients were in between certain heart rates. Again, so that change is now made, so that now again, a change that is in line with PALS as well as NALS. In terms of like when providers should be providing ventilation to chest complaints. Also, in addition to the key point section, there is a specific addition that's on there that does wants to just re-emphasize that providers should be using a PEEP valve if available when performing any assisted ventilations. Now, this one phrase that added to the key point section is something that we would also like to have added to the GOP airway management section, as well as to the non-traumatic cardiac arrest pediatric section, as well as to the pediatric respiratory distress and respiratory failure. It will be added to those respective points and considerations sections. As well, just as I think as a re-emphasis and good reminder for providers for a lot of these rare patient presentations.
Okay, any discussion on these changes?
Well done.
It's encrypted.
Encrypted.
You don't want to see
Does everybody have any questions about those changes? Okay, hearing none, we will move to vote.
Glennis Seda.
Yes.
Bradley Kaufman.
Yes.
Dario Gonzalez.
Yes.
Nathan Reisman.
Yes.
Pam Lai.
Yeah.
Just in my head.
Nick Alexander.
Yes.
William Hauser.
Yes.
Jeffrey Raybrick.
Yes.
Louis Marshall.
Yes.
Arthur Cooper.
Yeah.
Robert Winchell.
Yes.
Ed Jarvis.
Yes.
Mark Cantor,
Yes.
Robert Krupe,
Yes.
Stuart Kessler,
Yes.
Kevin Monjo,
Yes.
Cindy Bazilios,
Yes.
Matthew Harris. Benjamin Zabar,
Yes.
David Benelli.
Yeah.
Eric Lutiger.
Yes.
Eric.
All right, Dr. Lai, anything else?
So the next protocol that we have for bring forward is the changes to the anaphylaxis severe allergic reaction protocol. There we do have some significant changes that we discussed previously in medical standards. Of the significant changes, there is a new definition for. There's a new definition in terms of like how patients in anaphylaxis should be considered for this protocol. That is consistent with current medical literature as well as current recommendations from the National Allergy Society. In terms of anaphylaxis should be considered to be an allergic reaction with either respiratory compromise, signs of shock, or two or more signs and symptoms from any of the following symptoms, including skin, mucosal, or gastrointestinal. Or if they have a history of anaphylaxis and have had that exposure to a known pathogen along with one of those other symptoms on it. The other change that is here is also that we have changed the dosing for, in particular, for pediatric patients that's going to be less than 6 years old. Whereas previously they had the half unit dose for ipratropium bromide, which we did discuss that this is going to be safe as well as current clinical evidence by many pediatric intensivists. That we will be changing that so that now there will not be any age restriction for patients that will be receiving ipratropium bromide as well as butyl sulfate. They'll be receiving the same dose as adults. The other change that is on here is going to be something that is consistent with how our overdose protocol is written, where now that if we have a paramedic who is the first unit arriving on scene, that paramedic can start with titrating their doses of epinephrine versus having to go through the sort of the prepackaged CFR and EMT sections for the EMT dosing before they're able to titrate their doses.
Okay, any discussion on this, the changes to the anaphylaxis protocol?
I'm sorry, one thing just to add too, so that the change for the ipratropium bromide is also going to be reflected in the asthma COPD using protocols.
I think I was just about to say the same thing. Any discussion? So this applies to the anaphylaxis protocol and to the COPD and wheezing protocol.
Glenn Seda,
Yes.
Bradley Kaplan. Yes. Gary Gonzalez.
Yes.
Nathan Reisman,
Yeah.
Pam Lai,
Yes.
Nick Alexandru,
Yes.
William Hausner,
Yes.
Jeffrey Raybridge,
Yes.
Louis Marshall.
Yeah.
Arthur Cooper,
He said yes.
Robert Winchell,
Yes.
Ed Jarvis.
Yes.
Mark Hampton.
Yeah.
Robert Krupe.
Yes.
Stuart Kessler,
Yes.
Kevin Monjo,
Yes.
Cindy Bazilios,
Yes.
Matthew Harris.
Yes.
Benjamin Zabar,
Yes.
David Benelli.
Yeah.
Eric Lutiger. Carries.
Hey, Dr. Lot.
All right, so the last protocol that's coming forward is going to be a change to the emergency childbirth protocol. So Brad and Ben, please correct me if I say anything wrong, or if there's anything that needs to be added. But the change that's proposed is to move the needle cord deliveries, to move that from the EMT section into the CFR section. So this is proposed that this is part of the current curriculum for CFR. And I believe that there is some room in terms of the interpretation of the national CFR curriculum that's being taught in terms of whether or not renewable core delivery is considered to be part of a normal delivery, and whether or not that can be included in the curriculum. This is going to be something that is going to be a change, excuse me, a difference compared to the state's current ELS protocols. Just want to make sure that everyone is aware of that and the need that's going to be, the need for discussion is going to be, it's going to be occurring both at this level as well as the CMAC level if REMAC decides to approve it.
Any questions? Yes.
Yes, why?
Well, we've always tried to maintain consistency with the state BLS
Yes.
protocol. This is going to be a slight deviation, which is fine, and we're willing to have that discussion, but they've asked us to stay in as close as we can. This is, from my understanding, what is the EMD information that's given to lay people for these types of cases anyway. So I don't think that it's in their scope, it's appropriate, but it might come up and they might be frustrated about it. Brad?
So historically, this was part of the CFR curriculum and scope of practice. The latest iteration of the scope of practice, national scope of practice, limited CFR to normal delivery. And this was out of that and left in the EMT section.
In the educational setting.
In the educational setting. So the CFRs that we've been training have continued to receive this education. It seems critically important that they know how to do. And we feel that this is actually part of a normal delivery. So this change is consistent with that.
Any other questions or comments? All right, hearing none, we will vote on this change to the emergency childbirth.
Glenn Stater,
Yes.
Bradley Kaufman,
Yes.
Dario Gonzalez,
Yes.
Nathan Reisman,
Yeah,
Pam Lai,
Yes.
Nick Alexandru.
Yes.
William Haltner,
Yes.
Jeffrey Braybridge,
Yes.
Louis Marshall.
Yes.
Getting tired. Arthur Cooper,
Yes.
Robert Winchell,
Yes.
Ed Jarvis,
Yes.
Mark Cantor,
Yes.
Robert Krupe.
Yes.
Stuart Kessler,
yeah.
Kevin Monreal.
Yeah.
Cindy Basilios.
Yeah.
Matthew Harris.
Yes.
Benjamin Zavar,
Yes.
David Benelli, Eric Lutiger.
Yeah, the chair.
And this carries also.
Dr. Lai?
That's it from the protocol committee. So Marie, Michelle, I'll make sure that you'll have a package that'll be ready to go for
Okay, thank you.
Dr. Mallon?
Yeah, so I think those are the regular business from medical standards. We have one motion that would is moving forward as new business.
Correct.
Do you want to discuss this now? Or you want to
Yeah, no, we're gonna discuss it now, but Dr. Calvin, so you presented the whole Be Heard program at medical standards. I think if we could focus on the motion and specifically why it's relevant, and we'll focus on that instead of the whole program and move forward. That's okay.
I'll present it to sphere his vocal cord.
Excellent.
Basically, the Be Heard program right now operates with a mental health clinic and 2 EMTs responding to the scenes of selected calls for psychiatric emergencies. As part of our efforts to better utilize and spread this program across more of the city, we'd like an exemption from the REMAC staffing standards just for this Be Heard program, in which we'll send one EMT who's an experienced EMT who's been promoted to a supervisor, together with one mental health clinician in a non-transport vehicle to these calls. The calls they're responding to are only psychiatric calls where the caller on the phone has said that the person is not violent, doesn't have weapons, is not in imminent danger. They will have all the capabilities of the BLS unit. The social workers are already trained in CPR and bleeding control. If they come to the scene and the dispatch information was wrong and they require transport, they'll request a line unit to respond.
So the language that comes forward as a statement for medical standards is in front of you. Basically, it's for this program to operate with a single EMT as opposed to two EMTs and the mental health worker who, from my understanding, has basic CPR and bleeding control training. Good. Any questions about this motion? All right, hearing none and seeing no hands, we will vote.
Glenda Seda,
Yes.
Bradley Kaplan,
Yes.
Dario Gonzalez,
Yes.
Nathan Reisman,
Yes.
Pam Lai,
Yes.
Nicholas Alexander,
Yes.
William Halford,
Yes.
Jeffrey Rayford,
Yes.
Louis Marshall,
Affirmative.
at the Arthur Cooper,
Yes.
Robert Winchell,
Yes.
Ed Jarvis,
Yes.
Mark Cantor.
Yeah.
Robert Krupe.
Yes.
Stuart Kessler,
Yes.
Kevin Munjal,
Yes.
Cindy Basilios,
Yes.
Matthew Harris.
Yep.
Benjamin Zabar,
Yes.
David Benelli. And Eric Kluger.
Yes.
Harris.
Great. Thank you. Anything else?
That concludes the report from the Medical Standards Committee. We're next meeting, I think, on the 14th of November.
Great.
Virtually, no traffic.
Okay, just for clarification purposes, the Be Heard staffing standards that we just talked about, the emergency childbirth, the anaphylaxis and the medication changes are what will go to CMAC. The language changes that we've put in place, which are not medication changes, will be approved at this level and not go to CMAC for additional approval.
Why have you heard?
Yeah,
no?
Be Heard is-
Be Heard should be so.
It doesn't have the staffing
No.
standard, doesn't?
No, that's F.
That's a regional standard.
I like it then. Fine. Cancel that. Okay.
Yes.
Any questions? No. All right, QA report, Joe?
So the QA committee met on October 4th. We had representatives from New York Presbyterian Hospital, New York Presbyterian Hospital's EMS stroke unit. At the meeting, and they gave a presentation and an update regarding that program. So the program was originally running 3 units from 2018 to 2020 until it was temporarily suspended during the COVID-19 pandemic. It did relaunch in Manhattan with 1 unit in 2022. It is currently operating that unit. Currently, the program runs fully on philanthropic donations. And the program is participating as part in a number of studies with other programs, both nationally and worldwide, showing the efficacy of having such units. And they are attempting and working with CMS to get approval for reimbursement for this type of care. So the group gave a presentation with studies showing the efficacy. One of the highlights was showing that it did save an average of 30 minutes from last known well to TPA administration. After the presentation, the committee had a discussion to come up with some follow-up questions for the group. They did send us their presentation, and we will be happy to share that with and we did receive approval to share that with the rest of the committee. We'll make that available. The committee received an application from Staten Island EMT core sponsor requesting upgrade and approval to provide paramedic refresher training. That application is currently under review by the committee. We do have 1 pending regional restriction case labeled 23-02. We've received pertinent documentation related to that restriction case. However, we've been unsuccessful in reaching contact with the restricted paramedic to schedule an interview. If we do not receive any additional contact from the paramedic, we're going to place that restriction case on the back burner until the paramedic. The committee is currently developing 2 QA projects related to advanced airways and pain management, as Dr. Lai referenced before. We're pulling together some regional data on that related to those 2 studies. First Watch rollout is continuing. So we've been reaching out to agencies to update their user list with who should have access to the First Watch dashboard, as well as which specific providers will have the key code, knowing which agency on the dashboard is their own. So most of the major services and 911 participating services have responded to that. There's only a couple that we're awaiting their data. The meeting was adjourned at 18:05 hours. Our next meeting is November 1st.
Thank you. Any questions for Joe? Okay, hearing none, the training, education, interfacility transport and RTAC reports will be deferred because their representation could not make it. The regional council did not meet because they did not have a quorum. So that takes us to the CMAC update, Dr. Ravitch.
So CMAC met in September, the 12th and 13th. Just a reminder that Vital Signs conference is this week, goes through Sunday. Committees were busy meeting over the summer. Quality Metrics Committee put out a revised quality improvement manual that's on the Bureau's website. Take a look at it. Finance Committee released the results of a salary survey, which was actually responded to by a little more than 10% of EMS responders across the state. Basically, 73% of them reported working more than 40 hours a week, and 18% reported working 61 or more hours per week, and 85% said they've experienced burnout. And about 40% plan to leave EMS in the next 5 years. So not great numbers. The Finance Committee met with Training and Ed and provided funding recommendations to the Bureau on course funding. EMT original funding was actually increased by 38% and AEMT original by 80%. There's more funding pilots to come. The Legislative Committee met and there's a recommendation to the Bureau and to the state to modernize the definition of EMS to basically include things like treat in place and alternative destination transports and make that part of the definition of EMS and not just responding to 911 emergency calls, as well as a push to make EMS an essential service in New York State, which is not currently. Systems Committee released a trauma triage guideline resource to regions that may want to customize it. It's pretty much along the lines of the ACS one. There were some CON actions that were all tabled to December, mostly because the Bureau sent hundreds of pages of documents on the CON hearings several days before the meeting, and a lot of members felt they did not have time to adequately review all the paperwork, so that was tabled. What else? There was a discussion on the regional, whether the REMACs have the authority for credentialing. There was a motion that was brought up regarding that. However, the State Division of Legal Affairs basically ruled the motion out of order and said that it was not within the authority. So that's an ongoing discussion and debate. And I know there's a lot of people have a lot of feelings about, REMAC's ability to credential providers and know who's providing care in their region and how they do it. And I think there'll be more to come at the next CMAC REMSCO on that. If you remember, the representatives of the CMAC had met with FIPIC, which is the state's the committee for the state that basically is responsible for health planning and hospitals on ED boarding and ambulance wait times. And that committee is it's supposedly their #1 priority, and they're working on ways that they can get the hospitals to help improve this. But there's going to be follow-up meetings on that. And then that was pretty much it. Other than, as Dr. Cooper said earlier, there was a presentation from OMH on these crisis stabilization centers and additional CPAPs that may be planned in the state. It's in the very early stages. They did solicit feedback. There were a lot of good suggestions from the committee as to how they may want to roll this out and whether, they'll be receiving patients directly from the 911 system as opposed to taking PRs first. So they did a lot of listening and a lot of note taking, and we'll see what happens from that. The next meeting will be December 5th and 6th, also in Troy. And that's pretty much it, unless someone who was there has something else to add that I missed. Did you mention potentially?
Yes.
Yes.
Any questions for Dr. Rabbit?
Ask the whole group.
All right, I guess so. Okay. No comments, questions for Dr. Rabbit. Thank you. Lou, anything to add? No. Bob, were you there? All right. Marie,
Sorry,
go ahead.
real quick. We're not accepting the Department of Health's interpretation of Article 30 with regards to credentialing that they got from one of their lawyers that works for them. I have been in contact with an attorney that has expertise in Article 30. Right now, I'm in the exploratory phase, but we will be responding to them with a little more information.
Yeah, the impetus for those thing, there was a case, I believe, Western New York region, where that REMAC took action against a provider, and then the provider filed suit, and there was a whole debate and discussion about, whether REMACs have the authority to credential and then restrict providers. And the Division of Legal Affairs interpretation was that the REMACs don't. Many of the REMACs don't accept that. Many of the physicians on CMAC have concerns with that, obviously, right? Just like our hospitals credential people to make sure they're adequately trained and able to provide care in the region. We feel that there should be some input from the regions as well. So
In that case, the court found in favor of the provider. Right?
Yes.
Against the REMAC.
yes,
Correct.
So unfortunately, there is a legal precedent.
Right.
That's
what we're
binding or
fighting.
Not.
Right.
Yeah.
Well, the REMAC, so at that discussion, I actually was there for that. The discussion was that the REMAC made this decision. If we as medical directors of agencies in this region allow the REMAC to work like we do with our restriction protocols that we have, there is nothing that is illegal about that. Meaning it's the medical directors themselves have the authority to not credential people or whatever they want. But as a region, the REMAC itself doesn't.
Right.
So that's the argument that they're making. I think that Article 30 said something different, but that's just my opinion. And I'm not a lawyer.
their interpretation was that, yes, an agency medical director does have the authority within their agency,
Correct.
but that a region doesn't. That was my understanding.
A lot of the confusion, I think, comes up when you talk about definitions. So if you think about, we talk about certification and licensure, that really sets the minimum standard that allows an individual to do something that is restricted. So whatever CFR, EMT, paramedic.
Mhm.
Certification and licensure just sets the minimum standard for that. And credentialing is the clinical part at the medical director's level of the agency. You said if the agencies give that authority to the REMAC, then the REMAC can do it.
And we have that in New York City. Every ALS agency signs an agreement, their medical director and their CEO, that they will credential all their paramedics to operate in New York City.
Thank you. Okay, unfinished business. I don't believe there is any. If anybody can think of any, but there is one item of new business before we wrap up. Dr. Isaacs, who couldn't be here, asked me to bring this forward, and I'll bring it up for discussion. And if somebody wants to make a motion, we can. During the emergency order, the executive order gave paramedics who were part of a community paramedicine program the ability to perform vaccinations for non-emergencies, flu vaccines, COVID vaccines, whatever it is, with appropriate training, obviously. In our region, we developed a pretty robust training program. The state wanted us to use their training program. Most of the paramedics who vaccinated used the state training program. But now that the executive order has been rescinded, our regular paramedics who have the same level of training and have the ability to perform IM injections can't give vaccinations. So when an agency is trying to vaccinate their providers or whoever it might be, community outreach, there's no ability for them to provide simple vaccinations. Dr. Isaacs asked that we discuss it and possibly make a motion to go to the state to say that all paramedics, regardless of an EO or not, should be able to perform routine vaccinations. Any questions, Nick?
No, I make the motion.
Okay, so there's a motion and a second. Great. Any discussion on this? I don't see any reason why their skills change with an executive order or not. So I am in favor of it, but again, I'll leave it open for discussion if anybody has anything to say. Okay, hearing no discussion, we will vote on this. Maria, I would like to do this as a roll call just because it's going to go to the state and be discussed. The motion is to allow paramedics to provide vaccinations for routine vaccinations, exclusive of an EO or community paramedic level training.
Wouldn't that require a change in law to be able to do?
We're going to push it and see what happens.
All right.
I'm just wondering if that, is under a standing order or under a patient specific order.
It's not under patient specific. order.
Right, because I mean, we came across this when there were some EMTs also. We did training. But it was only with the presence of the standing order, and standing orders no longer exist for things like COVID-19. They do exist in health systems for things like flu. But the mandate from the state is that these types of things tend to have a patient specific order outside the confines of like EHS.
Right. I mean, again, that's a valid discussion point, and I think that right now, for the state to say that a paramedic can't do this skill is a concern in my mind. And I think that we should.
Sorry,
Good.
I mean, didn't the original policy just state paramedics to give vaccine, and then the emergency part was added in after the fact? That wasn't what we originally voted on.
So we wrote a policy and we sent it to the state at the beginning before the state said that we could do COVID vaccinations and so on. We had a whole education plan and everything. We submitted it all. Doug was the author of that and did a very good job with it. Then the state said, no, you have to use our training. It's only based on the executive order. When the executive order initially was rescinded, because there was a federal order, there were specific guidelines that allow paramedics to still vaccinate under the federal guidelines. But I don't see any reason why, if an agency, we'll use the fire department just because they're here, wants to vaccinate all their members, why a paramedic who can do the skill shouldn't be allowed to do it. Doesn't make sense. So I think that's the motion on the table, is that they should be allowed to do it regardless of an executive order or emergency or whatever it might be.
Interesting, in our paperwork, what we passed, right, our appendix order does have executive order. That's our paper.
Right.
So we want to kind of eliminate that piece.
Correct.
And the PrEP Act is no longer in place.
Right. The PrEP Act would only be based on a federal
Yeah.
emergency order. Nick.
Yeah, I just wanted to clarify because of the wording that was just discussed. All vaccines, we're still talking about the same vaccines that are in our protocols right now, which are the flu, COVID, and something else I can't remember.
So Julia, we worded
Because
regionally
we
approved
just mentioned
vaccines.
all vaccines.
Regionally approved vaccines?
I'm sorry?
Should say regionally approved vaccines.
Yeah, because otherwise,
we have
it
to
includes
expect-
all vaccines, it included, you know, I mean, I don't know that we're talking to that level.
But
There are three vaccines, there's three specific vaccines. in the protocol.
I think to your point, I think if you leave it vague, they're gonna shoot us down, right? I mean, I think.
Right, and make it the same, as I would think, make it the same as what's in our protocol right now, which is not a deviation.
1 second. Pesach and then Ben.
Just to clarify, this would still be paramedics who receive specific vaccine and training.
Correct. That's in our protocol. Ben.
No, I mean, I think just what Nick's saying, so right now we have a vaccine administration protocol, which has language about an executive order. And then we have appendixes, appendix Q, which spells out specific vaccines. But I think the appendix is really under our, I mean, is the motion to basically change the vaccine protocol to eliminate the part that says under executive order and.
Yes. And to open it up to vaccines that we have regionally approved.
Because I think even with COVID, we had to do the Pfizer educational piece and the Moderna.
Right,
Because
so,
there was a little bit of a difference.
right, but during COVID, we also had to do the state mandated training.
Well, we
for
took
everybody.
parts of it because it was a little bit, it was ridiculous, and we were waiting for them for so long.
Correct.
Yeah, weeks. When they said it was gonna be done in 2 weeks.
Yeah, currently in the appendix, it's only requires.
Correct. But again, if we say whatever is regionally approved, that would include if we added additional appendices.
I think it should,
Go ahead.
I think it should be more open-ended than what we have, because we don't know what's coming down the road. And similar to what we had during 9/11, was a question about smallpox. Anybody can give the smallpox vaccination, count to
Right.
15 and know how to do VBP. That's really all you need to
Right.
know. And so I think that what can happen 5 years or 10 years, we don't know.
I think if we say regionally approved, though, that definitely.
That leaves it open to whatever we have to add, yeah.
Okay. Art?
That was my question,
Right.
is the final form of the motion going to include regionally approved?
Yeah.
That would be good.
Thank you.
Okay. Any other discussion? All right, let's vote. I'm moving forward.
Glenn Sata,
Yes.
Bradley Kaufman.
Yes.
Gary Gonzalez,
Yes.
Nathan Reisman,
Yes.
Anne Lai,
Yes.
Nick Alexander,
Yes.
William Hauser,
Yes.
Jeffrey Raybridge.
Yes.
Did I pass them already? Okay, Lewis Marshall.
Yes.
Arthur Cooper,
Yes.
Robert Winchell,
Yes.
Ed Jarvis,
Yes.
Mark Cantor,
Yes.
Robert Cruzen,
Yes.
Stuart Kessler,
Yes.
Kevin Munjal. Kevin Munjal. Okay. Cindy Basilios.
Yes.
Matthew Harris.
Yes.
Benjamin Zabar,
Yes.
Paul Barbara. Paul Barbara.
Yes.
He's over there, he says yes.
Yes.
Okay,
In favor.
David Benelli. David Benelli, Eric Blumer. Eric, okay. Sorry, little beads there.
I think that will be a little bit of a fight, but I think it's worth it.
Yep.
Any other questions? Any other new business?
Hey, just one super quick thing I emailed to, maybe just check your mind and check it around. So there's a pretty low hanging fruit study that Sinai and Ace University are doing, which is looking just to recruit EMS physicians to provide medical direction to participate, I think, for an hour in this study. I think they have 2 sites to go to, one at Pace and one at Sinai. They're similar. Where they're ultimately looking at the differences in certain outcomes in simulated patients for paramedics obtaining medical direction, either by traditional radio or phone contact versus using these like Google glasses where the doc can see the patient and have all these visual cues. I'm not involved in the study. I just got a phone call about it today. So I sent the email to Marie. Maybe you could send it around. People are interested. About an hour at Sinai, what I understand.
What do they think? Or they give you?
Yeah, right. Yeah, right. Nothing. The benefit of participating in meaningful research.
Okay, I'll meet you.
Any other new business or informative information or anything? Hearing none, I'll entertain a motion to adjourn.
So moved.
Excellent. Thank you all very much for coming. Much appreciated.
Please do not hang around. If you have a car in the garage, leave. Because they're gonna, they want to get.